So they go there and they remain there for some time. So this is what is the primary tuberculosis FET. 90% cases resolved. They undergo calcification. This calcification occur in the lymph nodes, which you can see if we take a chest X-ray, which is one of the evidence that the patient had a attack of primary tuberculosis in the past. Then we discuss a little bit about the secondary tuberculosis. Remember, most patients with the secondary tuberculosis can have a history of the primary tuberculosis. So how to define this? This is a disease of lungs that arises in the previously sensitized host, and that is how you can differentiate a primary and secondary tuberculosis. Primary tuberculosis always occur in a patient who is not previously sensitized, and secondary tuberculosis always occur in the patient who is previously sensitized. How the patient was sensitized, or how the patient is sensitized? It means the patient previously had a tuberculosis. So this secondary tuberculosis can be classified into two basic groups: reactivation of the dormant primary lesion, and number two, exogenous reinfection. So these are the two mechanisms we can get a secondary tuberculosis. Now how can you get a reactivation? Think of a scenario. A child who is 10-year-old, he had a primary tuberculosis and it automatically got resolved. Now the patient is now adult, and now patient is exposed to some kind of immunodeficiency status. The moment the patient is immunodeficient, this bacilli which was dormant, which was remaining in the apex of the lung, will now become activated, and we get a secondary tuberculosis. Remember, this kind of tuberculosis is very dangerous and very difficult to treat. So what is the key point we are getting in a reactivation tuberculosis? That most of the cases, this tuberculosis should be located on the apex of the lungs, because it is apex of the lung where this tuberculous bacilli is actually located. And why it is apex of the lung? Yes, anybody can answer? Yes, you are right. It is due to the fact that apex of the lung has a very high oxygen density compared to the rest of the lungs. So the primary tuberculous bacillus, they go there, stay there for years, and once there is opportunity, produce second infection, which is known as reactivation secondary tuberculosis. So the bottom line is that you always check the apex of the lung if you suspect a secondary tuberculosis. Now the question is that this secondary tuberculosis, which is beginning as a small lesion near the apical part of the lungs or apical pleura, this secondary tuberculosis progresses quite often. So initially there is an early lesion which is nothing but a small focus of a granuloma on the apex of the lung. Now these lesions is very interesting to note, it will slowly progress. Now there are various kind of progression we can see. First one is known as a progressive pulmonary tuberculosis. So what happens in the progressive pulmonary tuberculosis? Now I will try to draw a picture for that. So let us see what happens in the progressive primary tuberculosis. So what I am trying to draw here, I am trying to draw a lungs. This is a lung tissue, and this particular person is having the primary tuberculosis in the apex of the lung, which is the most common location for the secondary tuberculosis. I beg your pardon, it is only the secondary tuberculosis in the apex of the lung. So when I say it is a progressive pulmonary tuberculosis, what happens? This tuberculous area or the granuloma progressively enlarges. it is becoming big and bigger. So as we see, it is becoming big and bigger, and it will involve a huge portion of the lungs. Not only that, it also can affect the other lung tissue as well. And here in the other lung also it can produce a huge granuloma. The interesting thing about this progressive pulmonary tuberculosis is that once it is becoming larger and bigger, what happens? You get a cavity at the center of it. So this secondary lesion always and most of the time they produce a cavity at the center of this granuloma, and by which you can diagnose this particular granuloma on a chest X-ray. So what we get here? We get a nice cavity. So secondary tuberculosis can be identified by the presence of a large cavity most of the time. So this is one kind of progression. What is the next kind of progression? This is very interesting. Now you know that caseation, what we see here, caseation is a semi-solid material. So some of this caseating material, it will erode into the bronchus because it is growing, so it will cause some kind of erosion of the bronchus, the major airway. Now this caseating material, which is now present in the bronchus, and patient will try to cough it out. As the patient is trying to cough it out, this bacillus or this caseation, which is containing the bacillus as well, it is traveling within the airways. So we get some kind of tuberculous focus or the granuloma along the pathway where this caseation is traveling. So we get endobronchial, endotracheal and laryngeal tuberculosis only because this caseating material is trying to come out as you are coughing, as the patient is coughing. This is sometimes known as endobronchial, endotracheal and laryngeal seeding of the secondary tuberculosis. What is the next thing? Sometime what happens, this tuberculous bacilli, it will produce a miliary lesion, small tiny areas of tuberculosis. So once again it is important to understand the picture. So this infection is now traveling within the lung and they are producing a tiny small granulomas which are known as miliary, very small. So the entire lung we can see this kind of miliary shadow. Miliary, always remember smalls. So this is known as miliary pulmonary tuberculosis. Now question is that how does it occur? How do you get a miliary lesion in the lungs? And this is via the lymphatics. So whenever we are getting a miliary pulmonary tuberculosis, it is the lymphatic spread. I was trying to write here, this is not working. So it is a lymphatic spread via lymphatics. Now there is another kind of miliary lesion we can find which is known as systemic. In that case what happens? In that case what happens? These tuberculous bacilli which are present in the bronchus and in the lungs, they will invade a blood vessel. And now the infection will be hematogenous. As it is becoming hematogenous, this infection would now travel to the various organs. So now